All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more special show that we are doing in the morning. Today with us is Dr. Shankara Chetty from South Africa. He is quite renowned, I believe worldwide renowned, popular for serving patients for COVID at this time with a lots of success. And actually, you can know nowadays the doctors who are popular, who are renowned, are the ones who are serving and helping. So many cool beans had requested us to reach out to Dr. Shankara Chetty to have him here, talk with you, present his protocol, discuss that with us. So we requested, and he has graciously accepted. So here he is. Dr. Chetty, welcome.
Thank you for having me, Dr. Bean.
So Dr. Chetty, tell us a little bit about yourself, your work, what have you been doing, your experience with COVID.
Dr. Mobeen, COVID started in South Africa in March last year. I watched the pandemic evolve from Wuhan through Italy and America. And I have a keen interest in the natural sciences. That is my forte. And so I was very interested in the virus, the science behind it, the pathology around it, the clinical presentations that we were seeing globally. And so I had already planned to look at this virus and look at the patients and how it presented before it got to our country. When we had the first case of COVID, I set up a tent outside my home with 3 rooms so that I could examine patients physically. The dyspnea was of concern. Around the world, everyone spoke of the dyspnea that patients were experiencing, which was leading to the hospitalizations and the deaths. So I was keenly interested to identify the dyspnea and what the cause of this dyspnea was, and exactly how it presented. So look, there was a lot of talk about the spread of this virus and keeping your patients safe, and my community were very concerned that they might not have access to medical care early on. So I assured all of them that I would be open. And with the tent outside my home, I employed someone to triage at my front gate so that I could keep COVID positive patients away from suspects and the rest that were coming for other reasons to my practice. And I endeavored to see and examine and treat every COVID patient. Very early on in the illness, Dr. Mobeen, I had to come up with a toolbox of what I knew that was working around the world. So early on, the protocol entailed azithromycin and hydroxychloroquine early on. We also knew that this was a steroid-responsive illness from the recovery trial that was done. So I knew that those were the 2 tools I had, 2 sets of tools that I had to treat this illness. I found early on that it presented just like any other respiratory virus with a sore throat, and we had the loss of smell and taste, which was typical of corona. But I was more interested in the breathlessness. So I advised every patient that I saw to promptly return if they noticed breathlessness setting in. And very early on, the first few patients that presented with breathlessness, I noticed that they had no wheezing, they had no crepitations, their lungs were dry, but they were breathless and they had a saturation drop. They were not acutely ill, like we would expect from a patient with an acute viral pneumonia. They were breathless, they had body aches and pains, they had fatigue, but if you view them from afar, they didn't look acutely ill. So this kind of presentation not baffled me, but I found it very strange that we were calling this a viral pneumonia and trying to treat it as such. And so I started by using steroids on that day that the breathlessness started. I was cautious not to use it early on in the illness because we're dealing with the viral infection, and I didn't want to impact on viral replication, neither did I want to impact on our immune response to that virus. So I started using steroids, and I noticed it took 2 or 3 days and patients showed good recovery. But by the fifth or sixth patient, I noticed that every patient that came back breathless seemed to come back on the eighth day, exactly 1 week after the onset of their symptoms. So I started to interrogate that presentation. And I found a majority of patients who presented back on the eighth day narrated a feeling of well-being 2 or 3 days before. They had thought that they had gotten over this. So it looked like we were dealing with a viral illness which clinically seemed to subside by the fifth or sixth day, with patients feeling a lot better by the seventh day. So I looked at it and I thought, well, there's something else going on this eighth day. And it seemed very precise. Every patient seemed to come back on that specific day. It seemed very precise and non-linear. The patients that presented back on that eighth day were not necessarily those that were acutely ill in the first 7 days. So I had patients who had very mild illness, very transient illness in the first few days, and they looked like they'd gotten over it, got back to normal activity, and then suddenly presented back on the eighth day with breathlessness. So I looked at that and I thought, well, if we're dealing with a non-linear illness, the breathlessness probably has some other root cause, rather than it being a progression of the viral illness. With looking at the breathlessness and from the views around the world, some people had very mild transient breathlessness on that day or a few days. Others had moderate breathlessness, but it persisted for a long period of time and took weeks to months to subside. And there were those others who progressed very rapidly and within a day or two became critically ill. From looking at that, I started looking at the possible pathologies for that presentation. And the only thing I could think of was a response of the body rather than the virus itself, a response to the virus, so that different individuals will respond differently. I also noticed that it had a genetic predisposition, where in certain families, the dad and the son were affected, and the mother and daughter were spared. They had the initial viral illness, but they did not progress to new symptoms post seventh day. So I started thinking about hypersensitivity. We tend to have a broad diversity of reactions to an allergen. And the reaction to an allergen doesn't have any bearing on the dose of that allergen. So I looked at that and I thought, if we're dealing with a hypersensitivity kind of reaction, then we're probably dealing with a mast cell activation kind of syndrome. So by the fifth or sixth patient, I tried an antihistamine on the eighth day. And very early on, I found remarkable results. Patients that were taking 2 or 3 days to recover from the breathlessness and the drop in saturations were recovering within hours. So I started to use antihistamines early on, and the drug of choice was promethazine, simply because it's an older H1 antihistamine with some anticholinergic effect as well, and some sedation for those anxious patients. My staff implored that I share this information, so I decided to write a little article that I published and sent out to all the doctors I know. My consideration was that we are dealing with what might be a type 1 kind of hypersensitivity, seeing that it was non-linear and very precise in its onset. So very early on, I added montelukast to my treatment, and we've heard about the clotting issues that we've had, and so I started adding Ecotrin to those patients who were not on any form of blood thinning or anticoagulation, or adding on clopidogrel to those who are already on aspirin. And I found that patients recovered very well with this. The oxygen saturation of my patients on the antihistamine showed a rebound within a few hours of starting treatment. So in the first wave, we got through about 500 odd patients. When I wrote my article, we had gotten through about 200. And it was the results were remarkable, and I couldn't ignore them. So I decided to publish that article. In the third wave, we had a flood of cases. We had a far more contagious virus. We had a different presentation to symptoms. And we had far more severe reactions post 8th day. So the breathlessness that we found in the second wave seemed to present a little later on, around the 10th day. But when I interrogated those patients about their symptoms, again, I found that patients were showing signs of recovery by the 6th or 7th day. And they were having new symptoms on the 8th day. But it wasn't dyspnea like it was in the first wave. They presented with fatigue or body aches and pains, and it took a day or two for the dyspnea to set in. So I decided to try and get these patients in early, because I noticed that every day lost made it difficult to catch them or to get them back. So I started educating patients about the importance of that 8th day and presenting back to me timeously. I was, if you could call it, fortunate enough to have 3 priests in the area develop coronavirus, and they had the reaction on the 8th day, and they came in and we promptly treated them and they recovered. And so they started spreading the message of the importance of the 8th day to their congregations. So very early on, the message spread in my community that we must get early treatment. So I had patients come to me on the first or second day of symptoms. I could take that opportunity to plot and educate them about their respective 8th day and to explain to them what the gravity of that day is and to present back timeously. So I had that happen and I managed to catch patients a lot earlier. And in so doing, I managed to prevent a lot of the hospitalizations and the need for oxygen. The recovery of decreased saturations was very remarkable. And I think that was the most important factor in me avoiding the need for oxygen in my practice. I've had patients present with saturations of around 70%. And within a matter of 4 to 6 hours, it recovered to 85. And within another 4 to 6 hours, it recovered to 90. So a day at home, a phone call a day later to make sure that they're doing fine. My staff were actually more shocked than I was because they spoke to the patients the next day to find out how they'd been. And they were shocked that a patient that came in that barely could speak the day before was able to articulate that they're feeling so much better, no breathlessness. So I found some very remarkable recoveries. However, patients that presented later on, past the 10th or 11th day, were far more difficult to manage. And I found that the need for steroids could not be averted in those patients. In those patients, the CRPs had elevated drastically, the interleukin-6 levels had elevated, and I was starting to see elevations in D-dimer levels. So I started to do serial measurements on some of my patients just to have a look at whether we can use these biomarkers to plot the course of the illness. And what I found was that from the 7th, 8th day, there was a steep linear to exponential rise in these markers. On the 5th and 6th day, they were elevated, but they were elevated to the extent you'd expect in a viral illness. So my CRP levels, which are usually below 5, in the first 7 days, they very seldom went above 50. But by the 8th day, they were in the hundreds, and by the 10th day, they were in the 400s. So there was a very steep elevation in those levels. So I used those levels as a measure of the efficacy of my treatment. Unfortunately, I'm in an area where there is a paucity of lab facilities, and I deal with a poorer population as well, who can't afford repeat testing and such. So I had to base my medication efficacy on clinical improvement. So every patient was educated about quick clinical recovery so that I could adjust the dosages of steroids timeously and not wait a few days for them to deteriorate before I decided to intervene. As well, I found that patients whose eighth day fell on a weekend, on a Sunday especially, could not have access to myself. I'm closed over the weekend. And by the time they got to me on a Monday morning, some of them had deteriorated very rapidly. So I decided that I needed to find a way to intervene more timeously in these patients. So I printed out a rescue script like I would do for patients who had bee stings and certain kind of anaphylactic propensity. And the script was for promethazine 25 milligrams 3 times a day with a dose of steroid added to it so that they could start timeously. And I put a leaflet onto the script to say, do not start this medication before, and in red, I would print their predicted 8th day. And it said only if your symptoms worsened. And you would add this to whatever treatment you were taking early on. And I found with doing that, a lot of patients, it bought a lot of time for patients to get to me without their condition worsening. So when you look at the overall protocol that I used, my first 7 days of treatment was to treat a viral illness. I've never used antivirals. Viruses tend to be relatively self-limiting, and we've known all along to treat them symptomatically. For those patients where I found the need for an antiviral, those that had symptoms of viremia, very high fevers, body aches and pains that were very severe, and were not showing signs of remitting over the first few days, I used hydroxychloroquine in them, very sparingly, just for those patients who had those kind of symptoms. And I found by the 6th or 7th day, they had improved. So my whole aim in the first 7 days was to get patients well prepared for what might transpire on that 8th day. On the 8th day itself, I still am of the opinion that we are dealing with a hypersensitivity reaction, however it may be triggered. We're having a mast cell activation type of syndrome with a huge release of histamine. And I think that's the reason I've seen the remarkable benefits with antihistamine on that particular day. What I found was that on day 8, if I caught a patient early enough, their blood markers showed raised CRPs, raised interleukins, and an upward trend in their D-dimers. However, with promethazine alone, I was able to get their oxygen saturations to rebound, and over a day or two, their CRPs, interleukins, and D-dimers returned to reasonably normal. But I must stress, Dr. Mobeen, that when we're dealing with those kind of patients on the 8th day, there's a variety of different severities dependent on the patient itself. So in those patients where I was suspicious of a more severe reaction, I initiated with the addition of steroids to the montelukast and the aspirin, which was the mainstay of what I did. Those patients that presented later were a lot more difficult to manage. And I noticed that the dose of steroid needed to be much higher in those patients to suppress this reaction. I've been following the work of Dr. Malik and Dr. Corey and Dr. DeMello in India. And I noticed that the D-dimer levels seem to elevate around the 12th to 14th day. That's why I started to see a rise in those values. And so I quickly realized that we might be dealing with a biphasic illness, viral in the first 7 days, and inflammatory afterwards from the 8th day onwards. But that inflammatory phase could have been broken up into different parts. The first being what seemed to be a mast cell degranulation, a type of hypersensitivity trigger. And if it was caught at that time, you could negate what was to follow very easily. But if the patient was having a very severe reaction that you didn't catch timeously, or the patient presented a day or two later, we were now dealing with a hyperinflammatory phase. And Dr. Malik's work was very important in helping me get patients through that phase. If that's not treated timeously, by the 14th day, we're going into a hypocoagulability phase. And so the anticoagulation becomes important in that phase. Unfortunately, I don't have the access to hospitals close by. I'm 35 kilometers away from the nearest private hospital and about 50 from the nearest public hospital. So anticoagulation, I had to do at home. I found that the clopidogrel tended to help a lot of patients, but those that went into hypocoagulability with the raised D dimer levels, I put onto oral anticoagulation using a drug called Xarelto. The Xarelto was used at 15 milligrams twice a day to bring the D dimers down. And I found that worked very well with patients. So all in all that I've treated, I've had some complicated cases. Unfortunately, I don't have a good team around me to actually hospitalize those patients that needed hospitalization. And of course, the hospital protocols in South Africa were following a very different regimen. And so patients as well refused to be hospitalized. So I had to do ICU treatment on an outpatient basis. In doing all that, I managed to keep all my patients out of hospital. I managed to negate the need for oxygen in my practice. As well, I've had no deaths or long COVID cases. I think the longest case was 3 weeks. He was a guy that presented on the 14th day. He had lung symptoms, severe cough. He had a superimposed bacterial infection on that, but he recovered, and it's taken a while for him to get better, 3 weeks or so, but he recovered fully, and I haven't had any sequelae, any complications. I haven't had any blood clots later on. I've had one patient that's become diabetic 3 months after his COVID illness, and he was one of the most severe cases that presented. He was my first case in the second wave. It took me a while to realize the severity of the second wave and the new variant we are dealing with. So I blame myself a little bit for not being able to suppress it timeously, but he got through it, and he taught me a lot for the next patient that I had to look at. One other thing I noticed, Dr. Mobeen, in the second wave, we had the notorious South African variant. And from looking at the genetics of that variant, the mutation had caused a change in the spike protein. That spike protein was 30 to 60 amino acid base pairs longer than the original wild-type spike protein. And from looking at the cases that I saw in the second wave, the virus was far more contagious. And that ties in with this difference in spike protein. We also saw a lot more gastrointestinal symptoms on presentation in the second wave. And that probably is a propensity for the ACE receptors in the gut. And then I noticed on the 8th day that the reaction that was triggered was far more severe than anything I'd seen in the first wave. So it drew my attention to the fact that the spike protein might be implicated as the trigger to the hypersensitivity that I was seeing. But I think the research in that field is ongoing, and hopefully we get some answers and we can suppress the reaction a lot more easily.
This is very interesting. So sorry I stayed quiet. I didn't want to interrupt and break the chain of thought and the medicine's usage. I wanted that to be seen together. So
yes.
this almost seems like magical, that nobody
Yes.
needed the oxygen, although they dropped their oxygen levels a lot. Nobody was hospitalized. That means I would assume that nobody died either.
Yes.
And so for the cool beans here, this is what happens when a doctor is trying to sincerely manage their patients and is not looking for some big studies or RCTs or what would FDA tell us or what would WHO tell us. The doctor is sitting in their clinic thinking, I have to help my patients. I have to figure this out. And that feeling and motivation then drives the doctors to find solutions. So here we have someone who has found solutions and then shared them as well. So Dr. Chetty, Before I ask you the next question, so there are a couple of things that we'll do. There are some questions that I have. So once again, thank you very much for sharing the information. There are some questions that I have. There are some questions that the Cool Bean community that is here, they have. Before that, if you are okay, I want to quickly show your articles and the South Africa's cases as well, just so that we can talk a little more about ivermectins and hydroxy as well. So if you are okay, I'm going to very quickly show here. So this is one of the articles by Dr. Chetty. This is Roundup Windows on the World, a KZN doctor's observations and treatment of COVID-19 reveal a missing element. So here, Dr. Chetty is talking about the same discussion that he just did about the day 7, day 8, and then possibility of the mast cell activation syndrome, or MCAS, and how to then manage it. Then here is one more article, beautifully written, and I love this one, Lifelong Learning Virology. Dr. Chetty, is this available somewhere online?
Dr. Mubin, it has been published in Modern Medicine, which is a educational journal.
Got it.
It is available online. I think if you go to my profile, either on LinkedIn or on Google, it has been published to the general public there as well.
Cool. So what I'll do is this, for the Cool Beans, I would get the link after the talk, and I would tweet that link out. Plus, I'll post that on the YouTube as well as a post, and on Facebook too. So that you can reach this document. It is a beautifully written document, an important document. And what we have here is, if you look at this is the description of the virus and then the clinical presentations. And then as you reach here, this is a very important point here, that there is unusual symptoms of hypoxia which do not correlate with the lung damage. And then there is the treatment toolbox. And if you see here, there is a discussion of hydroxy, azithromycin, doxycycline. And here, if you look at the protocol, all of those drugs that Dr. Chetty just talked about, they are here too. So I wanted to give you a glance of his work that you can then see online as well. And finally, before we continue with our questions, this is South Africa. So Dr. Chetty, tell me, how is South Africa doing? Here is what, according to Worldometer, the cases look like. You're in third wave. How is generally South Africa doing? At one point, we were very scared that they have a new South African variant and that is going badly. What is your take on this situation?
Dr. Mubin, in South Africa itself, a lot of doctors look for randomized controlled trials before they would ever look at any protocols. And we generally have been following the World Health Organization protocols in the treatment of COVID. It has been an uphill task to get my work seen in this country. Unfortunately, doctors early on were encouraged not to physically see patients. And that created a lot of problems in South Africa. We have a diverse population, and we have a very diverse socioeconomic structure. So early on, the government instituted lockdowns in an attempt to curb its spread. However, we have a large contingent of our population that live in urban settlements that are very overpopulated. And so isolation and lockdowns were not the ideal measure to try and stop the spread of this virus. So we had a rampant spread in the first wave amongst mainly our Black population, who don't have the ability to isolate themselves. They live in quite close quarters. So we had a rapid spread of the virus in that first wave. However, the wild type variant didn't present with such severe manifestations post-8th day. So from my perspective, a lot of those patients were relatively easy to treat, to get through the illness itself. In the second wave, the government, I think, abandoned the plan of lockdowns because it never worked in the first. So in the second wave, we really didn't have lockdowns, and the virus spread quite rampantly through the population. But strangely enough, we saw a different population group being affected. So in the second wave, my patients were predominantly of Asian origin. The Black population seemed to have been spared, and there were very few and far between. Now, in the third wave, I am seeing more of the Caucasian population being affected. Now, whether this has something to do with genetic predisposition of the different variants, or whether it has to do with the different populations' ability to lock down and isolate themselves, needs to be looked at, I think, a little more closely. We've also had a slow vaccination rollout. So up to this point, vaccination hasn't really impacted on the illness itself. So I think that a lot of what you see in those graphs is the natural spread of coronavirus in a population where lockdowns and that kind of thing really were not of the most important contingent.
Got it. So also want to see just a quick second here. I want to see the number of deaths. It is interesting to me that the second wave was more lethal compared
Yes.
to the third one. Are you seeing a similar take as well?
Yes, Dr. Mobeen. I would compare the first and the second. Like I said, the second wave, we seem to have far more severe allergic or hypersensitivity reactions on that 8th day, which were far more difficult to curb. And I think that's the reason for a lot of the deaths in that second wave. As far as the third wave goes, we have just entered the third wave. In Gauteng, which is a province about 700 kilometers away from where I am based, we are reaching the peak of that third wave. However, in KZN, we are still on the upslope in the more populated cities. I live in a holiday destination that's not very populated, and I'd say over the last 2 weeks we have noticed the new cases coming in. So I think we are about 2 weeks away from our peak in my area.
Got it. And I pray that you do not see more peaks and you continue to be successful with your patients and they do not go to hospitals, they do not die. One question I have while I'm going to look at the vaccine, and for the cool beans here, when I look here, I have a monitor on this side, which I have those graphs on. So I'm not looking away from you or doctors. I'm looking here. And when I look here, again, not meeting you eye to eye, I'm looking at your comments here. So please give me that allowance to look around to moderate this. Dr. Chetty, while I look at the vaccine, question for you. During this whole time that you are exposed to the patients, you do not have hospitals nearby, you and your staff is yourself managing patients on daily basis. How are you protected? Were you doing any prophylaxis or did you catch COVID, you, your staff? What was your own situation?
In the first wave, I put my staff and myself on hydroxychloroquine, a very low dose once a week. It seemed to keep us fine, but to protect my family, I had to move out of my home. I took a flat and I isolated myself from the general public. I limited my interactions to only my patients. As to my staff, Dr. Mobeen, we all wore double masks, we all wore visors, but there was a lot of controversial publications coming out about the spread of this virus, about spread through fomites and that kind of thing. If you looked at my article, I fell back on my knowledge of respiratory viruses. Respiratory viruses we've dealt with over many years. And so I felt that the most important measures were sunlight, ventilation, and of course, sanitizing and keeping your hands away from your face. And so that was the measures we put in place. And my staff we knew that this was going to be a very difficult task. We knew that we were putting our lives at risk to do this. But after the first month or two of seeing patients, we realized that we're reasonably safe, God willing. And through this pandemic, I haven't been ill. Neither have any of my staff members gotten ill. However, 4 months into the treatment of COVID, Dr. Mobeen, I realized the recovery of my patients. I hadn't had a death. I hadn't had a hospitalization. So my son came to me and he wanted to know why I'm living away from home, if I could treat myself if we got sick. So I moved back home and now I'm back with my family. My practice is in my home. And so we take the necessary measures to isolate ourselves. I wouldn't be surprised if I was one of those asymptomatics who now have immunity. So I haven't wanted to Murphy's Law. I
Got
didn't
it.
want to test myself and see if I have antibodies till we pass that point.
Got it.
So
Got it.
we've
So
all managed to keep pretty safe.
got it. Thank you very much for that. And one more glance at the vaccination side as well for South Africa. So, cool beans, here is the vaccination status for South Africa. Here we have South Africa, 2.2 million about doses, and really low, one dose 3.8%, and two doses 0.8%. So, at least from the Bloomberg's point of view, not a lot of vaccination that we can depend upon and say something to do with the vaccination. So I'm going to go back to the questions. Dr. Chetty, more interesting questions for me. How about ivermectin? Have you used it? Is it allowed? Is it not allowed? We heard a lot that South Africa banned it. There were people who were being arrested for using ivermectin. What is the situation? Tell us how that went.
Look, very recently, one of the hospitals were raided for stock of ivermectin. So that is ongoing. There has been a suppression of its use. It might not be overt, but through the governmental regulations, making it a Section 21 drug, it has forced doctors to look in other directions for treatment options. As far as ivermectin goes, I did use it in the first wave. I managed to get 20 tablets from a friend of mine in India. The reason I looked at ivermectin, Dr. Mobeen, I was aware that I was dealing with a hypersensitivity kind of response on that 8th day. And my understanding of this was that on that 8th day, we were having the release of chemical mediators, histamine, leukotrienes, platelet activating factor, and my aim was to mop those up. If I wasn't timeous enough, then I would expect the inflammation in the lung to be primarily eosinophilic. And so I looked at ivermectin because ivermectin is one of those drugs that has the ability to clear pulmonary eosinophilia from its use in the treatment of filarial illness. And so that was the main reason why I chose ivermectin. I was considerate of using diethyl carbamazine citrate, which is another drug that's used to clear an eosinophilic lung in filariasis. However, that's not available here in South Africa. And those 20 tablets, I actually used them in patients who showed a drop in saturation. I gave them a single dose, and I noticed within a day or two an improvement. And all with that single dose seemed to recover. So I used 20 tablets on 20 patients in that first wave. I did not manage to get any ivermectin from that point on. However, now in the third wave, it is a little more freely available. But again, I think because of the paucity, we got to use it very sparingly. So I tend to reserve the use of ivermectin to post 8th day. If
Got
the
it.
patient has ivermectin, they usually have a tablet or two, and I ask them to just keep it handy. If they have a reaction on the 8th day, that's where I've seen the benefit. I'm aware of its benefits in the early stages of COVID. And from my friends in India that I've been keeping in touch with, I'm aware of its prophylactic benefit. A lot of them have used it and with great benefit to them.
Got it.
So ivermectin is a drug that works in all the phases of this illness. Unfortunately, we don't have access to it. I have a doctor in Meghalaya in India, and I've had patients take ivermectin in the first few days, but still progress to a reaction on the eighth day. And that was the reason why I asked patients to hold on to it till post eighth day. So I was not convinced of its early benefit. It seemed to not stem the reaction, and I expected that ivermectin would provide me some immunomodulation in that early phase. However, there's a doctor in India, Dr. Hazarika, and he's been using ivermectin in a higher dose. He's been using a TDS for 3 to 5 days. And what he's found is that by doing that early on, he hasn't had patients progress to the second phase of this illness. So I think the immunomodulatory benefit of ivermectin might be dose dependent.
And I
And for a
have
drug like that, it should be investigated further.
I have a similar experience. So for me, I use ivermectin very profusely wherever I can
Yes.
for prophylaxis for my patients. And then during acute disease, right from the day I find out they have symptoms or they contact me with symptoms or suspicion that I got exposed to someone, I start ivermectin 12 milligram or 0.2 milligram per kilogram body weight or higher nowadays for Pakistan, India like places.
Yes.
And I just continue to administer that daily until they come out and they say, I'm good. And I have two outcomes. One, you are correct. None of my patients still today that started their therapy with me has ever needed to go to a hospital. And secondly, none of them became long haulers, except I have three patients who did become long haulers, but all three of them did not use ivermectin. Those were the days of hydroxychloroquine when I managed them. And none of them afterwards have become a long haulers or afterwards became having symptoms. So I have a question for you. On the so do you still use hydroxy before I go to long haulers? Do you still use hydroxychloroquine?
Yes, what I found in the first wave was that I used hydroxychloroquine I chose that drug for two reasons. I knew that it would have an immunomodulatory benefit for my patients, but also I knew that it was used extensively as an antiviral, a general antiviral in the armies, and there's been documentation about its antiviral properties. So those were the two areas that I looked at, and I thought, well, it's got a dual benefit. So I needed to investigate how this would pan out. But very early on, I noticed that patients that were put on ivermectin still progressed into the 8-day scenario. But those patients that had severe viral illness seemed to recover with it because I had no other antivirals that I could use. And so I reserved the hydroxychloroquine for those patients with severe viral symptoms in the early stages. And I gave it to them at a dose of 200 milligrams daily for 5 days. And all those with severe symptoms seemed to resolve. My aim being to have them better by the 7th day, so that I'm not dealing with an overlap of symptoms post 8th day.
Got it. Got it. Thank you very much. So there was a troll in the comments, and I was looking at their. I was blocking them. Apologies. Sometimes I have to. There is a question from. This is directed at me. If you don't mind, I can very quickly answer this question. There is a Carl Papa who put this question here. Carl, I usually do not respond to these questions, but the question is that why was I validating Gates' study? So yesterday's talk. Look, Gates does not need my validations for their studies. The reason I talked about that study yesterday was that people were reaching out to me saying that I am deliberately not talking about a study that shows spike proteins in the blood. So I thought it was important for me to talk about it, put that in front of the cool beans. Then we can make our own decision to see how valid or invalid that is. So that is why I presented it. So sorry, Dr. Chetty, I wanted to make sure I respond to that. So tell me this, Dr. Chetty, over here in the US, there is almost a mini pandemic of long haul syndromes where people who have the infection or nowadays even vaccine, we are seeing that there are symptoms that just continue afterwards, and not the sequelae. I'm not talking about the lung damage that has occurred or pancreatitis, that damage to pancreas that has occurred. It is the COVID-like symptoms, but hills and valleys. Do you see that as well in there within your own management, the patients that you managed?
In the second wave, when we approached the second wave, Dr. Mobeen,
Mm.
I had the opportunity, none of my patients became long haulers or presented with long COVID. But as we got close to the second wave and people started realizing that I had published this article, I started having people driving from far and wide to come to my practice with their symptoms. And it was the first time that I had started to see these long COVID symptoms. And it was the symptoms were typical of what I had seen on the 8th day, but it waxed and waned. Patients were having bouts of breathlessness, intermittent fevers, but very different from what you'd find in an infection. They would have a spike in temperature and then afterwards be perfectly fine with absolutely no symptoms. There was the brain fog, there was the lethargy and the tiredness, the generalized body aches and pains. From looking at my understanding of the pathology or the pathogenesis of the illness, I was under the impression that this was a continuous mast cell activation kind of syndrome. And if we did not stop it, we'd get this waxing and waning of symptoms. So I treated patients with the same type of modality, with antihistamines, montelukast. I did put some patients on aspirin, those that I was suspicious might have clotting issues dealing with. And those with more severe reactions, I initiated the treatment with a short dose of steroid, just to suppress any reaction that was there. And I found that within 3 to 5 days, a lot of them recovered. I kept them on the steroid for a prolonged period, some a month or two. We were going at that time into season change, so I was worried about atopy as well, factoring into this kind of degranulation. Since I've had a conversation with Dr. Tina Pierce, she's, I think, holding a conference soon about long COVID and that kind of thing.
We just had that this weekend we had it. I actually presented the management part of the long COVID.
Okay. Yes, she contacted me. I think she saw one of my podcasts or something, and she realized that what she was doing was very relevant. And so we had a long chat about that. And the mast cell MCAS is actually likely to be the cause of this long COVID. And if we clear up those mediators that are constantly being released, we've had good recoveries of patients. Just to fill you in, Dr. Mobeen, there's been a doctor here in South Africa who a month ago decided that he's going to try my protocol on his patients. He was approached by one of the heads of a doctors association in the state. And so he's an intensivist who runs a tented hospital setup with ICU facilities and the rest. And in the first wave, he spent his time chasing oxygen. And he contacted me and said, I've lost a lot of patients in that first wave. In the second wave, he moved on to the proper World Health Organization protocols with remdesivir and Dexona and the tocilizumab and the rest. And again, in the second wave, he lost a lot of patients. And so when he was approached to look at my protocol, he promptly decided to run all the relevant blood tests and that kind of thing. And I got a call from him 2 days ago. We keep in touch now. And he said, look, I've been through 150 odd patients and I haven't had a hospitalization or death yet. Neither have I needed oxygen. I've invested all this money in oxygen and now I don't need it. So he's seen the benefit. But what he did as well, which I asked him to actually look at, he had a lot of long COVID patients from the first and second wave. And so I said, look, the protocol, if we're talking about a mast cell activation syndrome, then the protocol would work for patients with long COVID as well. And that's what I've seen. But seeing that I don't have the lab facilities available, I asked him to run certain tests and to clarify what I had seen in a few patients. And he had patients with long COVID for over a year who recovered within a week of starting that kind of treatment, had a drastic improvement in their symptoms. But the one thing we noticed, In the first wave, when I had noticed this eighth day phenomenon, I needed to prove it, that I was seeing a sudden burst of histamine release. And if that was left unchecked, it was going to lead to hyperinflammation. And if that was left unchecked, it would lead to the hypocoagulation. Now, to test that histamine release, I had a few options available to me. To test histamine, I needed to do a 24-hour urine collection. That was not very feasible for two reasons. It wasn't very practical to send the patient home with a container to collect 24 hours of urine. Secondly, I had to withhold treatment for 24 hours to collect that histamine before I could start treatment, and I knew how detrimental that 24 hours could be. So I abandoned that test. The second was tryptase, to look at tryptase levels. Unfortunately, tryptase was an exorbitantly expensive test, and tryptase levels are not very accurate and not very predictive of mast cell degranulation. The third was to look at immunoglobulin E and see if there was a spike in that. However, immunoglobulin E as well is a very slow marker to show up in the blood. So if I could not have something on the eighth day to show this change, then it was not worth anything to run these tests. However, long COVID patients had sufficient time to develop the relevant markers that we could look for. So I started doing immunoglobulin E testing on all the long COVID cases that I was seeing. And I found marked elevations. The normal is below 100. I found patients on average with immunoglobulin E's close to 1,000. I've had a lot of them with values in the 3,000 and 4,000 range. And when I put them on treatment and they started to recover, I repeated those values, and you could see a definite steady decrease in those values. So it drew my attention to the fact that we're dealing with a hypersensitivity kind of reaction, and if we can suppress this mast cell activation, we probably would be winning.
Got it. Thank you very much for this part of the talk. I think it is very important for the countries like mine, like the US, where we are not doing much in terms of usage for hydroxy or usage for ivermectin or early aggressive treatment. We are fortunate that our cases are now down, but we have long COVID, and it is an important outcome that we have to manage quickly. So thank you for sharing your information here. Now, as we are moving towards, I know we've taken 1 hour from you and very valuable. Are you okay if I can ask some questions from the Cool Beans
Yes,
as well?
sure.
Perfect. Thank you very much. So, Cool Beans, if you had written your questions before, please put them once more. I'm going to now look at some of the questions and ask them. So I'm going to start from the most latest. So there is no bias here. It's just that previous questions have scrolled up. So we have Dr. Amir Hashmi. He says, some folks in India are saying third wave coming, question mark. So again, these questions are directed at you, totally up to you to take them or pass on them.
Yes, from my colleagues in India, it seems like they are in a third wave. However, I think we must be cautious about calling them by the first, second, and third wave. Here in South Africa, we had the first wave, and it spread from province to province. In that time, from my understanding of the pathogenesis, we were seeing in the first wave a lot of older people being affected. And it seemed to spare people below 55, somehow. In the second wave, we had young people affected. Now, I looked at that in the first wave, and I thought, well, if we're dealing with the hypersensitivity and it's only affecting an older age group, are we dealing with a younger age group that's not previously sensitized? And if in the first wave they get sensitized, they're going to present with severe illness in the second wave. And so I warned about that we might see a very young population being sensitized in the first wave and presenting with severe illness and death in the second wave. And in the second wave, that is what we saw here in South Africa, a far younger population. And that became my measure of a second wave, that we'd see younger people being affected. Now, the second wave spread through the country, but it seemed to spare Gauteng, which is the province now that is having its peak in cases. And I'm a little suspicious that that peak in cases is actually a late second wave rather than the start of a third wave, because the rest of the country seems to be slowly on the uptake in a third wave, whereas a few provinces who seemingly were spared the second wave are having a drastic rise in cases. So there seems to be this lag time between waves. But for all intents and purposes, in India, they are going into their third wave.
Got it. Thank you very much. There is a question from Svetlana Podkolzina. Could we ask what dosage of hydroxy the doctor used for his own prophylaxis and for the prophylaxis of his staff? He said just once per 2 weeks. So what dose and probably the frequencies here?
We used hydroxychloroquine at a dose of 200 milligrams once a week. That was the dose that we used.
Got it.
We had no access to ivermectin, and if we did, that would be my drug of choice.
Got it. On the hydroxy, did you see any side effects in the people who were doing prophylaxis?
No, not really, Dr. Mobeen. I haven't had a single person have side effects with that medication.
Excellent.
It's a long, old, trusted medication. I did keep very cautious about the cardiac side effects and the rest, but I've used it extensively in the treatment of rheumatoid arthritis previously, and I've never seen any problems with it. So,
got it. Thank you. Luis Grande says, what can you tell us about availability to vax and therapeutics in South Africa and other areas in Africa? So the availability of vaccines and the other drugs, not very good info in US. Also opinion regarding WHO efficacy in this pandemic, many not impressed. So let's keep the two questions separate. The first is, what do you think, what is the availability of vaccines and the drugs in general?
Vaccines were not available in South Africa for a long while. The vaccine rollout took a long while to actually get on its feet. That was because of the legal issues around the waiver of liabilities and that kind of thing. Recently, the government secured a large batch of J&J vaccines, and the rollout with that had started. However, there was a call back about some manufacturing issues with those vaccines, and so we had to halt again our program. Now they've secured some Pfizer vaccines, and so the vaccination is back in full swing. So we've had a lot of pitfalls. However, the vaccination program has been slow in South Africa. And unfortunately,
Alexa, stop. Sorry, please.
Unfortunately, the vaccines haven't really played any role in South Africa itself till now. From the perspective of early therapeutic intervention, South Africa, in the main, has not restricted its doctors from treating patients in any particular manner. There have been some recommendations. The hospitals seem to be forced to follow the World Health Organization protocols. But as general practitioners in the country, we were left to be kings of our own domain. And so we were allowed to use whatever drugs we felt were required for each individual patient. And fortunately, that allowed me the latitude to do what I've done and to figure out what I have. So from a therapeutic perspective, there hasn't been any stifling of early treatment in the country. I think a lot of the stifling of early treatment came from the outside governing bodies like the World Health Organization and those kind of... I reassured my patients that I'll be available, but when I went onto my website, I saw a red warning saying, do not go to your doctor. Please stay at home, call him first. I thought that, and they put it onto my website without my permission. So I think a lot of the fear and a lot of the GPs that closed their doors during the pandemic was because of outside intervention, or I would call it meddling, in the way we were, as doctors, were expected to run this pandemic.
Got it. So the second part from the same, from Lewis, do you want to share your impression of WHO, and totally up to you to pass it or comment, whichever way you like.
I think that with the WHO and the recommendations so far, there has been a huge disconnect. I think that's going to take a whole program for us to discuss every point that's come and gone so far. I think I think, Dr. Mobeen, that we should have been more considerate of the doctors that are physically seeing and treating COVID to formulate our perspectives and our protocols as to how we should be managing this pandemic. We did the preventative measures and we skipped the early treatment completely and went straight to vaccinations. And that's cost us a lot of lives in the long run. So the WHO needs to have a good look at itself. And I think at the end of the day, whatever we advise or omit to advise, we need to be accountable for. And I think that's very important in this.
Absolutely. And for the cool beans in general, what I have noticed in my life so far is that for communities, for countries, sometimes there is one or two people, there are one or two people who just change the fate of that community in a positive way. So here you're looking at a person who looked at his community, hospitals are not nearby, drugs are not available, and he changed their fate. This is what happens in all area where humans are under stress. So WHO did their work or they did not do their work. I really feel that these heroes would keep emerging who would take their communities and save them and move them forward. And this is why from the day one, when people would reach out to me separately and say this pandemic is going to kill us, I would say no, humans are very resilient and they'll come out. So you would see those individuals surfacing and then leading. So, Dr. Chetty, once again, thank you very much for being with us and for your leadership in saving not only the communities, but the world as well, as you're sharing these data points and therapeutics. There is a question from Lori. This may be a mixed question for you and me. Lori says, suffering from long haul COVID, I am currently on Dr. Bean's FLCCC protocol. So I have a protocol on FLCCC for long COVID, which has ivermectin, fluvoxamine, steroids, MCAS, and mast cell activation syndrome treatments. And she's saying that at what point should I consider MCAS? So I'm going to give a quick answer from me, and then I would request as well from Dr. Chetty too. Lori, if the ivermectin or fluvoxamine is not helping, then I would go to steroids plus MCAS management. Dr. Chetty, what do you think? When should the MCAS management start for long COVID?
Look, the MCAS management can be initiated anywhere in the COVID illness. Basically, my protocol on the 8th day is the start of MCAS management. And if we do not start it timeously, we'll have the other effects from it. Now, long COVID, I think, is a moderate reaction that has a moderate release of histamines and mediators, and if left untreated, presents with this prolonged syndrome. And so wherever you are in long COVID, if you start to initiate MCAS treatment, you will have a benefit from it. However, there are some injuries that occur with long COVID, and MCAS treatment isn't going to solve those. We got to look at the hypoglycemia. We got to look at the COPDs that can result from this. We have to look at the thrombotic injuries or ischemic injuries that might come from these kind of long COVID symptoms. And of course, each patient is slightly different. I found that in some patients, especially those that presented with brain fog, aspirin seemed to settle it. However, I found some good benefit with ginkgo biloba. Ginkgo biloba has ginkoside B in it, which is a platelet activating factor receptor antagonist. And I found that it helped patients clear out that brain fog. So I'd say the MCAS treatment should be about the mainstay, and all drugs that influence your mast cells would be potential candidates for this kind of treatment. We'd have to work out, the different doses and different patients and what seems to work for them. But as long as we understand the pathology that's going on and the pathogenesis of that pathology, then we'd have a wide toolbox to actually treat it and can individualize that treatment for each respective patient.
Got it. Awesome. Thank you very much. I'm going to keep asking you questions till you say done.
It's fine.
So here is one more question. From the very first day, Dr. Chetty, this particular channel, I tried to come out with the intention of serving. So I do not care for time that much. I do not care for what are the questions. Because of this, sometimes these talks become long. I'm very, very grateful. It is evening in your place in South Africa. So we would try to wrap up as quickly. Some more questions. That is my greed, to get as much things.
As long as it takes, Dr. Mobeen, I don't mind at all.
Thank you so much. Liza says, Dr. Chetty, are you seeing reinfections in your practice? So you're seeing patients coming back with the infections?
In all the patients I've seen so far, I haven't had a single reinfection. I've not had a single patient come back with COVID again. But that is a figment of the poor quality PCR test. I cannot send every patient for a PCR test. So I had to limit. In the first wave, the government sector helped. And so we could send every patient with a sniffle for a PCR test. But in the second wave, it became for the patient's account. And in a poorer community, I couldn't waste money doing PCR tests on patients. So every patient that had the flu was treated like a COVID suspect to isolate. The only patients that I sent for PCR testing were those that came back on the 8th day with recurrence of symptoms, and I needed to document that. So I haven't seen a single patient come back with another COVID infection. Just to touch on that, our South African blood services in the second wave, they did antibody testing for patients with no history of coronavirus infection and no history of a flu or anything like that prior. And what they found was that 64% of blood donors with no history of COVID were positive for antibodies. And so I was of the opinion that we're getting to herd immunity without the vaccine being there. And it bore out in the second wave because I saw very few Black patients coming in. So it seems like the virus spread through that community. The ones that had critical illness, I managed to get my hands on quickly enough and save those lives, but we got to herd immunity. And so in the second wave, the Asian population were hiding away in the first wave, thought it's safe to come out, and so the virus caught them in the second wave.
Got it. Thank you very much for this. Craig has a question. Do you think the nature of promethazine, being an FHT, 5-hydroxytryptamine antagonist, played a role in the serotonin overload-related vasoconstriction caused by platelet degranulation in the lung? From Drbeen, South Africa.
Yes, the promethazine tends to have a wide diversity of benefits. And those benefits all seem to have an impact on the illness post-8th day. Promethazine is an old antihistamine, and so it has the anticholinergic effects. It has the antihistaminic effects. It has some have a little bit of antimuscarinic effects. So I use that medication because it is the mainstay in treating anaphylaxis. We need all those different benefits from it. So I think it does have a benefit in its action on serotonin. In the first wave as well, adrenaline is the mainstay of treating anaphylaxis. However, in my practice, I don't have the necessary staff to use adrenaline and monitor patients. So I decided that the easiest route for me to administer that adrenaline would be through an adrenaline nebulizer. And so those patients that came in critically ill, where they were starting to develop crepitations in the lung because of extravasation of fluid, I nebulized them and with adrenaline. And I found very quickly, within an hour or so, that it dried it out. And so I could go to the other medications from that point on. But promethazine is, I would say, the gold standard for treating anaphylaxis. And of all the drugs that I've used, I would say it is the one that most efficiently and timeously reversed the hypoxia.
Got it. Thank you very much. The next question is from Gaurav Shah. He says, 1 year back, I had COVID and 15 days later developed severe allergies, similar to hive urticaria. Now, 1 year later, similar thigh has happened to me post Covaxin vaccine. Kindly guide about treatment. So they had allergic reactions or allergy-like symptoms after the infection. Now they got a vaccine and they have similar outcome. What should they do?
I would think that it is exactly the same. We're having a mast cell degranulation again. The culprit still in my mind is the spike protein. The vaccines tend to expose you to that spike protein. Like we have a section of the population who progress into the pulmonary phase of this illness, I think that pulmonary phase is those people that are allergic or show hypersensitivity to that spike protein. In a very similar vein, we're going to see about the same proportion of people show hypersensitivity to the vaccine, being the spike protein. But the treatment for that would be the same, to stabilize mast cells and to mop up all the mediators from that degranulation that occurred.
Got it. Thank you. A few more questions. William Goff says, can you give more specifics on day 8 protocol? Promethazine 25 milligram thrice a day, how many days? Also specifics on the dosages and days of which H2 used, also steroids, which ones, day, dosage, etc. And if it is somewhere written, we can publish that later on as well. So totally up to you.
Okay. The promethazine, I used a dose of 25 milligrams 3 times a day. You can go up to 4 times a day, 100 milligrams being the maximum daily dose. The sedation was a concern, so for my older patients, I decreased the dose. There is a 10 milligram tablet available in South Africa, and so I titrated it accordingly. The promethazine was continued till I had the biomarkers back to baseline. In those patients where I had no access to blood testing, I would use clinical improvement as my marker. So I would keep patients on promethazine for a variable period of between 3 and 7 days, and all patients in that time showed recovery of their symptoms. However, I was wary of withdrawing the antihistamine too quickly and having a rebound. So I would change patients over once they were clinically recovered to levocetirizine, which of all the non-sedative antihistamines seemed to be the best. But I would start them on a double dose of 5 milligrams twice a day for a 4 or 5 day period, just to make sure I wasn't getting any rebound allergy symptoms. And if that was the case, if there were no rebounds, then I would decrease them to once a day for a period of a month. That's the promethazine. The H2a antagonists, we saw a lot of gastroenteritis in the second wave. That gastroenteritis was very refractory to all the conventional treatments for a runny tummy. So the antidiarrheals didn't work, the PPIs didn't work for the heartburn and reflux. We didn't have the nausea medication, didn't seem to suppress nausea. But I was of the opinion that the reaction we saw in the gut was hypersensitivity as well, a type of mast cell degranulation in your gut, but that would require H2 antihistamine. So I started using cimetidine. It's the commonest and cheapest available drug in our country at 400 milligrams twice a day. And when I started using that drug, I saw the improvement very quickly. Within a day or two, diarrhea settled, nausea settled, and your H2 antihistamines tend to work in the entire gut, rather than your PPIs just suppressing acid in the stomach itself. So the H2 antihistamines were initially reserved for patients that had gastrointestinal symptoms, and it was added to the promethazine. from the perspective of the steroid, which I think is vitally important, I didn't use the steroid at all in the first 7 days for fear of triggering an increase in viral replication or suppressing good immunity to the virus. But it was vitally important to suppress the reaction post 8th day. In the first wave, I found that a starting dose of 40 milligrams of prednisone, and why I chose prednisone was simply because it was a broader acting steroid compared to dexamethasone, and cheaper and far more easily available, and I could use it in home treatment, not injectable medication. And I found that the minimum effective dose in the first wave was 40 milligrams. Now, it took a little bit of trial and error to come to that dosage. I noticed when I started patients with a lower dose, some of them would progress. So I realized that the minimum dose is 40 milligrams. And with that 40 milligrams of prednisone, I wanted to see patients recover very quickly. So if by the evening the patient wasn't showing signs of recovery, I gave them another 40 milligrams. And by the next day, it was a TDS dose. Those that had 40 milligrams and showed recovery, I'd keep them on that dose for 3 days. And if the recovery persisted for those 3 days with no new symptoms, I would then endeavor to slowly decrease that steroid. So the steroid was dependent on, in the first wave, the severity of that initial reaction. And the increase in the dose of steroid had to be rapid to get a quick turnaround in their symptoms. However, in the second wave, we had a far more severe allergic reaction on that 8th day. And within the first 3 or 4 patients treated, I realized that my minimum dose needed to be at least 80 milligrams of steroid, of prednisone, and which became the standard of treatment for my practice. However, again, we did have those patients who on 80 milligrams did not respond, and I had to quickly increase the dose. The maximum I've needed to initiate with has been up to 100 milligrams of prednisone 3 times a day. Now, that might seem a very high dose of steroid. However, I'm of the opinion that we are treating a pulmonary pneumonitis, a hypersensitivity pneumonitis kind of lung pathology, rather than a typical viral pneumonia. And the protocols for treating hypersensitivity pneumonitis have steroid dosages up to 1 gram of prednisone a day. The whole aim is to give a high enough dose to suppress the reaction. The aim is to avoid intubation and ventilation. And if you use an inappropriate dose of steroid and allow the reaction to persist, you're going to have that patient on steroids for a far longer space of time. So we'd rather start early and aggressively, and we'd shorten the length of treatment, rather than be very tentative in the way we initiate treatment and have that patient ill for a far longer period.
Got it. Thank you very much.
The dose was dependent on the variant in that case. So I think every country very early on needs to look at their variant and decide what the minimum effective dose of steroid should be, so that we're not starting too low. And we have a minimum dose to titrate up with.
Got it. So one more question, and we'll make this our last question as well. There are many more questions. I apologize. We'll request doctor to come back. So Denise, she herself is an expert, I believe, in mast cell activation syndrome. She has been, I believe, a patient of this. Denise says, hydroxyzine also acts on serotonin and is anticholinergic and antihistamine. Therefore, in your opinion, could this be a reasonable substitution? I think she may be talking about promethazine.
Yes. Hydroxyzine can be a substitute for promethazine. Unfortunately, it's not a commonly used medication here in South Africa. And the reason I did not attempt it was because of the cost concerns. But it would be a good alternative to promethazine.
Got it. So with this, we still have lots of questions, and I think we'll have to just continue to get back to you to request to give us more time. Thank you very much for your time today. Thank you from me, and thank you from my team, and thank you from all the cool beans. You are actually a super cool bean for the work that you're doing. Thank you very much.
Thank you, Dr. Bean, and thank you for allowing me the opportunity to share my experience on your platform. it will save lives.
Thank you very much. And Cool Beans, thank you very much. I would see you this evening at 6 o'clock. We'll have Dr. Drbeen with us, and tomorrow we'll have Dr. Bruce Patterson with us. Thank you very much and stay safe. I'll see you tomorrow, this evening.